Hello, everyone, and welcome to Grand Rounds. We are honored to have Dr. Nate Kupperman speak with us on the myths of DKA today. As a reminder of those attending virtually, questions can be posted in the Q&A throughout the lecture, and you can join us for a more informal meet and greet at the end of the presentation by asking the host to unmute you. The Mach 2 codes will be posted in the chat and displayed in the back of Rangos. Dr. Kupperman is a distinguished professor of emergency medicine and pediatrics at the Beau Thomas Brofield Endowed Chair of the Department of Emergency Medicine at UC Davis and Associate Dean for Global Health at the UC Davis Health. He's a pediatric emergency medicine physician and clinical epidemiologist, and a leader in emergency medical services for children, particularly in multicenter research. His focus is on clinical trials and clinical prediction rules using large cohorts of acutely ill and injured children. He has published works in all three focus areas in high-impact journals such as the New England Journal of Medicine, JAMA, BMJ, and The Lancet. Dr. Kupperman has received more than $50 million in federal grants and contracts as a PI or co-PI, and has published more than 295 peer-reviewed publications with a Hirsch Index of 72. He's been a leader in multi-center research in PEM, starting by chairing the first U.S. research department in PEM, the Pediatric Emergency Collaboration Research Committee of the AAP, PEMCRC, from 1996 to 2000. He then became the founding chair of the Pediatric Emergency Medicine Care Applied Research Network, PECARN, since its inception in 2001 until late 2008, and remains one of the 7 network PIs. He recently completed a 4-year term as chair of the executive committee of the global Pediatric Emergency Care Research Network called PERN, and continues as a leader in PERN. Dr. Kupperman has been recognized nationally and internationally for his research and mentorship with many awards. In 2017, a PEM Scientific Research Mentoring Award was named after him by the Society for Academic Emergency Medicine, and in 2020, he was awarded the UC Davis Hibbert William Extraordinary Achievement Award and the Faculty's Distinguished Research Award. He was a Fulbright Distinguished Scholar in the UK, and in 2010 was elected to the National Academy of Medicine. In 2022, he was the recipient of the Maureen Andrew Mentor Award for the Society for Pediatric Research. Please join me in welcoming Dr. Nate Kupperman.
Okay. So good morning, everybody, and who else is on virtually? I'm really happy to be here, and thanks so much for inviting me here to Children's of Pittsburgh to talk about this about 25-year adventure that I've had investigating DKA along with my wife, Nicole Glazer. You see that I put her name on the slides as well because this is a true collaborative partnership over the last 2 decades and some. So my connections here to Children's of Pittsburgh, they kind of go way back. I'm just going to name a few brief stories. First of all, I want to say that my connections really started pre-Pittsburgh. Good friends with Janet Kinane and Rick Saladino during our time at Boston Children's, and then in the venture of PECARN, became good friends with Bob Hickey, and that continues to this day. Jen Marin's a good friend also that we've sort of crossed paths many times and are good buddies. And I have to also say that last night we went out for dinner and I was surprised and excited to see Loretta Mateo. Loretta was, when I was a second-year resident at Harbor UCLA, Loretta was the chief resident. And I'm telling you, I'm not saying this just because I'm lecturing on DKA. I remember presenting a case of DKA to Loretta when I was a second-year resident and she was the chief resident at Harbor UCLA. And the last connection I'm going to mention about Pittsburgh is that Dr. Dorothy Becker and Dr. Mark Sperling, they and Nicole and I, we have chatted and sparred over DKA for years in a most jovial way, but also an important part of this journey. So, and I hope that, by the way, the last thing I do want to mention is that your division of emergency medicine here is really outstanding. And, sometimes this is very common. We all are not acknowledged much at our own institutions. That's just standard. Everything is just like expected in our own institutions, but outside they seem like they're diamonds in the rough and whatnot. But you guys have a really outstanding division, and I hope that Dr. Dermody is somewhere out there listening to me. And if not, someone can convey that to him. So although I'm a peds emergency physician, I chair a general department of emergency medicine at UC Davis. And actually that's very purposeful because the collaborations between peds emergency medicine and general emergency medicine, I think are fundamental for the health of children in the country. As you know, many, if not most of you know, between 85 to 90% of children in our country seek emergency care at community general EDs treated by our general EM colleagues rather than by us. So we went there because you can do your research anywhere, but for me, training people that care for children, I invested in the general emergency physician. And by the way, I have, because I'm the chair of a general emergency department, I have strong connections with your sister emergency medicine, adult emergency medicine department. I'm good buddies with Dr. Don Yealy, Cliff Calloway. So the connections run both in the pediatric and adult side. And finally, I just want to say I'm overjoyed that we are partners in this grand venture of PCARN. Bob is a big participant, and it's really through these sort of collaborations that we move forward. And a lot of what I'm going to describe today in DKA occurred in PCARN. So with that, I'm going to move forward, and I am going to talk about this journey. I'll finish it within 45 minutes, so we'll have. You guys can tell me and yank me when I'll be off. I'll be off in time, and how it started and where we are now. And let's see, the advancer is not working, even the old-fashioned way. I guess, do I have to click forward arrow? Okay, it's always good the first slide to have technical problems, but okay, there we go. It went. Anyway, I have no financial conflicts of interest to disclose, although I have a small disclosure here as well, because, and I forgot to mention two other people. Dr. Noel Spears has been outstanding in sort of organizing all of this and putting up with me and all my late minute stuff. And Savannah Ryder has been just outstanding. I want to recognize Savannah as well. So I forgot that, like, in my small print. But one thing with the disclosure, when you speak, you have to give your financial disclosures. It's very interesting. If you go to Europe, they give a talk, and there's all these people, and they're talking about a product, and they're clearly making money off it, but there's no disclosure slide. It's really interesting. So I always talk about the disclosure slide to my trainees, how important it is. So I have a disclosure that Nicole, my wife, so she runs the pediatric diabetes clinic at UC Davis, and she invented a small wheel. It's a wheel, it looks like a pregnancy wheel, but there's 12 versions, and they help children dose their using typed. Okay, perfect.
Just click here.
Okay.
And it will fit. So we'll figure out what that
Okay, sounds good. So she created this wheel, and it basically works like the pump, but only about 40% of her patients want to use the pump. So she created this wheel, got a grant, and made several thousand, and then they give them out free to the clinic, and then they ran out. And then, but her patients were clamoring for the wheels because you throw them away. They're these cardboard things. They last for a year. And so I helped her into the ADA to see if maybe they would buy the wheel and distribute it. That no one wanted to touch it because of everyone's risk averse, because if you get the wrong dosing wheel, that's potentially a risk. So finally I said, okay, I'm going to help you out. We're going to create a company. The interest was not to make money. And I'll tell you, we really did not make money. So we created a company. You can go online. It's called insucalc.com. And we created wheels for adults and kids. They're just so that Nicole could distribute them to her clinic. We've been in business for 20 years. We've lost $100,000 in 20 years. Okay. Now, but first of all, I have a partner, Doug Nelson, who's another peds emergency physician. So actually, they lost half the money. We lost the other half the money. But it's been a good tax write-off. And kids around the world, we've sold actually 500,000 of these wheels around the world. losing money every year, but to the benefit of children with diabetes. That's my financial disclosure. So, okay, so what the objectives, what I'm going to talk about for the next 40 minutes or so. First, I'm going to review recent studies, particularly pertaining to cerebral edema, cerebral injury, because that is the biggest killer of children with DKA. I'm going to talk about some articles that we've recently published regarding sodium trends during DKA and acute kidney injury during DKA. And then I'm going to finally discuss how all these recent data should inform your clinical practice. So just a couple of slides of background epidemiology on DKA. About 2/3 of all deaths in children with diabetes are one way or another associated with DKA. And of pediatric deaths due to diabetes, about 90% are actually caused by DKA, and 2/3 of DKA-related deaths in children are the result of cerebral injury/edema. And you're going to hear me speaking using the term injury more than edema, because this is part of the paradigm shift. Edema is a secondary event. It's not the primary event in pediatric brain injury and DKA. So you're going to be hearing me talking about cerebral injury. And the mortality rate for children with the full-blown type of cerebral injury DKA is about 20 to 25%, and permanent neurological morbidity in another quarter. So, one of the interesting things that we've seen, and this is pre-COVID, you can see the dates, there's been a rising frequency of DKA at the time of diagnosis of children with type 1 diabetes in the United States. You can see from 1998 to 2016, all pre-pandemic, those numbers increasing. Lots of potential hypotheses, but part of it likely due to the abysmal access of care that many children in our country have to primary care, and then they just present with DKA. It's interesting, in countries that have very high frequency of diabetes, particularly in Scandinavia, DKA presentation is very uncommon because they're aware of diabetes and they see their practitioners have early signs of diabetes, and not here. And then we also know many people documented that during the pandemic, DKA was more, severe DKA was more frequent. So we're going to talk about what's new in DKA management. And this is sort of how it was back in the day. This is when I was a resident, with Loretta, we would go to the library and you get a book and you read about everything about DKA. And this would be what the textbook would have told you in the mid-1980s. That first of all, DKA is a complication of type 1 diabetes. It's treated with insulin and IV fluids. Slow and cautious fluid administration is important to prevent cerebral edema. Monitoring serum sodium levels to ensure a rising sodium level during treatment is also important to avoid causing cerebral edema. BRAN and creatinine are somewhat elevated in DKA due to decreased renal perfusion, and it's resolved with fluid management. And most children recover from DKA with no long-term consequences. That's what you would have learned in 1985. By the way, is on Zoom, can people hear me? Sounds good? Yep, we're good? Okay, great. So we're going to take a Miss Butler's approach to those 6 statements, and we're going to see where we are in 2023 on those statements. So the first 2, I will tell you, the first one we know, as an aside, it's not that these are all wrong. Some remain true, some are partially true, and some are absolutely wrong of what we were taught in the 1980s. The first one I will add that DKA is a complication not only of type 1 diabetes, but it's also a complication of type 2 diabetes. And yes, DKA is treated with insulin and IV fluids. But that's about how far the complete truths go. And now we're going to talk about the slow and cautious fluid administration to avoid cerebral edema. And of course, I will tell you as a clinical epidemiologist, the best research ideas I've ever had is inpatient care. And this was a patient that about 25 years ago, this is the Sacramento River near where I live, a 4-year-old patient presented to the ED in Florida, had cerebral injury/edema in DKA, and we hadn't touched the child. And not only that, when people said, oh, they drank themselves into cerebral edema. Kids with DKA do not drink themselves with cerebral edema. They're vomiting like crazy. They're really sick. This child was really dehydrated, needed intubation, had cerebral edema injury. And that made me think, and Nicole was a consultant as the endocrinologist. Well, that's weird. That's not what I was taught, as a resident and fellow. So that event 25 years ago started down this path of investigation. And I would say, many of my colleagues, clinical investigators, will say the same thing, that something that they saw or cared for clinically really triggered their research investigation into the topic. So this is an example of, again, I don't name the investigators. It's all well-intentioned, but the way people did research in the 80s around clinical epi was just not to the same standards of what we need now. So this was a very famous case series in the 1980s that suggested that cerebral edema was, much more common in children receiving larger volumes of IV fluid. And in this case series, you can see it was in Journal of Pediatrics, 1988. What they did is they accumulated 40 cases retrospectively, not only at their institution, but at other institutions. They just wanted to send us cases of DKA with cerebral edema. So they accumulated 40 cases, and only 4 of the 40 cases of DKA occurred with fluid intakes of less than 4 liters per meter squared per day. Now, what that translates, it's like 1.5 maintenance or a little bit more. But the point is, that was all they looked at. They didn't look at what else is common around them, how sick they are, how dehydrated. They just looked at fluid, and there was no comparison arm to compare with. But they concluded, wow, this is the answer. So as a resident, I don't know, Loretta, if you remember this, but I remember this, 4 liters per meter squared per day. That's what we were limited to based on this case series. And the hypothesis, of course, is that rapid fluid infusion or rapid change in osmotic shifts lead to DKA-related cerebral edema. And we'll look at that in a second. Now, as importantly, that article published in 1988 was followed by an editorial. And this is what the editorial said. Again, I'm not naming the people. I'm not like accusing them of bad science. It's just the way science was done then. Well, based on this article, emergency resuscitation should not be given unless there are signs of shock. If emergency phase is needed, aliquots of 5 to 10 cc's per kilo only. Brain swelling during treatment of severe DKA is a tragedy that now can be prevented. This is what they wrote. Okay, so then there's the hero of the story. It's not me or Nicole, but this personnel name. Elliot Crane is a pediatric intensivist who's about to retire. He might have retired. He's at Stanford. He was studying DKA in the brain in the 80s. And in fact, Nicole and I were communicating with him at the time because he had some really interesting pathological slides of children who had died that was showing infarcts and strokes. And he said, this is not cerebral edema. Anyway, so he wrote a letter to the editor. It was a few months later. It was published in 1989 because back then, of course, it's paper publication. So it takes a long time to get it into print. But he was responding to that article and that editorial. And he said, to state that brain swelling during treatment of severe DKA is a tragedy that now may be prevented is unsubstantiated and does little else than give plaintiffs' attorneys the rope with which to try to hang pediatricians who have had an unfortunate encounter with this complication. Until basic research defines the pathophysiology of cerebral injury during DKA and randomized prospective trials can be done, we are all guessing about how this elephant looks. He was very prophetic, and actually, every so often, we've never met him. We've just communicated electronically. We've pinged him, and he's promised us now dinner at Stanford some point in the near future. And by the way, I can tell you how true this is because over the last 20 years that we've been studying it, Nicole and I have gotten medical records, legal records to review for physicians that did totally reasonable care, and the child had this unfortunate event. And all of these cases, we've defended the clinicians. Not that, if someone told me you drank a bottle of vodka and operated on someone's brain, I'm going to testify against you. But these were all reasonable cases, reasonable care, and the children all had the high risk factors that I'm going to talk about. But this is one of the consequences of science that is not done with great precision and great accuracy. So this is, again, what we taught. I'm sure you've seen this one. We'll walk you through. This is the astrocyte in osmotic equilibrium with the extracellular space with osmolytes there. And then in DKA, can you see is the arrow there? Yeah. So then there's hyperosmolar stress because you're very hyperglycemic, and then fluid. This is what we were taught. Fluid leaves the cell because of all the extracellular osmolytes, and then the cell creates those idiogenic osmoles, the term that we all used to maintain the osmotic equilibrium between the cell and the extracellular space. And then in this frame here, there's a sudden decrease because of IV fluid or IV insulin, and then fluid then now floods the cell and you get cerebral edema. This was the pathophysiology that we were taught. So if we apply a sort of a Mythbusters approach already to that, we can see from research that we've done over the last couple of decades, not just us, but others, many children present with cerebral injury and edema at diagnosis before IV fluid. So the case that I saw, it's never an isolated case. We published an article, this was in, I think the pediatric article in 2021, documenting the number of cases that you see at presentation. And the difference is that the retrospective studies, when you review, they only identify the patients when they're like herniating 6 and 8 hours later. But if you do it prospectively and follow people with their GCS drops, this happens very early, not all the time, but a substantial portion of the time. Andy Muir identified that edema often is not present on initial imaging of the children with these complications, but develop hours or days later. And in a recent publication of our PECARN study, Nicole and I published that children with higher serum sodium, a lot of osmolytes, higher serum glucose, are not at greater risk of cerebral injury. So these are already sort of questioning that etiology of cerebral injury in DKA. So then we did our first big multi-center study, and I want to take a moment to talk about this because it's important. It's the power of collaboration. This is not PECARN. This was before PECARN. You can see this was published in 2001. We did a collaboration in the Pediatric Emergency Medicine Collaborative Research Committee that about which Bob had mentioned. It's a committee of the AAP. And we thought, you know what, we really need to do a study where we have cases and we have controls, and we do a multivariable analysis to see what are the factors that we can find. So you can see these are, and Rick and Janet can recognize, there's a bunch of these people that were like PEDS EM fellows with us in Boston. And the second author, Peter Barnett, is a PEDS EM trained physician with us who is from Australia. Anyway, we identified 7,000, we went through all of our medical records over a 15-year period at 10 institutions. We identified all of cases of DKA, 7,000, and 61 of those had the full-blown cerebral injury edema, either intubation, death, etc. And what we did is we did 2 multivariable analyses. We compared those cases to random DKA controls, and we compared them to matched DKA controls, matched on certain elements of severity. And what we found, lo and behold, and this was, so you can see this got into the New England Journal, a retrospective chart review. There were 4 factors that we found that were associated with cerebral injury. One was a high BUN, a low PCO2, so the acidotic hyperventilating child. The third factor, and probably the reason this got in the New England Journal, was a modifiable factor. There's administration of bicarbonate after adjusting for acidosis, after adjusting for all these factors, is associated with cerebral injury. And the last one, which I'll talk about later, had to do with serum sodium. So normally, as you know, with DKA, you have hyperglycemia and you have pseudo-hyponatremia, the dilutional effect. And as you treat DKA and serum glucose normalizes, the serum sodium should normalize as well. But we found, and others have found the same thing, that failure of serum sodium to normalize was also associated with cerebral injury. But note, what we did not find, fluid wasn't involved, the amount of fluid, the fluid bolus, the IV insulin by push or by drip, none of those were factors in this big study. Again, sort of validating some preliminary stuff we did. Interesting, what happened after this is a retrospective study. No one changed their fluid management. I mean, people waved this article around, but what they did do, people stopped giving bicarbonate, more or less. But fluids, man, that has been like ingrained in our souls forever, and people just were scared. Oh, retrospective study, we don't believe it. Okay, but then others along the way found the same things, that epidemiological studies around DKA cerebral edema. These are the factors that others found as well. High BUN, low bicarb, Julie Edge in England, acidosis, low initial sodium. This is the study I just talked about from Nicole and me, high BUN, low PCO2, and Mahoney found low PCO2. Again, fluid not appearing in any of these epidemiologic studies. So now we realize, okay, we're onto something here. So now we got to investigate it further. And this is, by the way, one of the joys, as peds emergency physicians, and I know many of you here are, we are the experts of the first hour of care of a lot of things. But you do find a lot of joy when you can do the deep dive into a few things and can, develop some expertise. So this was an area that I took a deep dive with Nicole. So we realized now we need to use sophisticated imaging techniques to see what really is going on in the brain of these children with DKA and DKA cerebral edema. So we first used a technique called magnetic resonance imaging, where diffusion weighted imaging. And what DWI, the abbreviation for diffusion weighted imaging, does, it measures the random motion of water molecules in the brain tissues. And it's quantified as the apparent diffusion coefficient. I'm going to show you an image in a second. And molecules of water that are an extracellular fluid, they diffuse easily and they have a high ADC. And molecules of water that are inside cells, they don't diffuse easily because there's membranes and organelles and whatnot, and they have a low ADC. Yeah. So this is, so when you have cytotoxic edema, so that's like from ischemia or osmotic cellular swelling, you'll have a low ADC because the fluid is in the cell, and again, it limits the flow of fluid. In vasogenic edema, what you see in tumors or in reperfusion injury, there is fluid in the extracellular spaces, and there's free flow of fluid with a high ADC. So this is what vasogenic edema looks like. Like I said, with reperfusion injury, lots of fluid moving in the extracellular spaces, high ADC, but with cytotoxic edema, with sort of cramped quarters in the cells, you have low ADC. So to study this, we also realized that not only do we need to image children, but we needed to be able to image people at time zero. And you can't image using DWI, it's an MR technique, children with DKA, because you have to resuscitate them before you can image them. So we had to create a rat model, a juvenile rat model of DKA. And this is again the importance of collaboration with our basic scientist colleagues. So at Davis, we found great collaborators who are studying using a juvenile rat model to study stroke and brain tumors and reperfusion injury. And we created a DKA model because we need to do imaging at time zero as well as at the time where we normally image children with DKA. So this is a graph that I'll explain. On the y-axis, that's the ADC. That's the one that I'm talking about, the fluid, the motion of fluid in the brain cell. These are rats, not children. This is the ADC of normal little cute juvenile rats. Okay, that's the normal ADC. Those that are dehydrated, still not with diabetes, just dehydrated rats, it doesn't change their ADC. But DKA, this is time zero in rats, you can see a low ADC. So this is before IV fluids, before anything. This is akin to that cytotoxic swelling of the cell with low ADC. And then we expand this. This is again the control rats that are normal, the rats at time zero with DKA. But now, 6 hours after treatment with fluid and insulin, the ADC, that is actually statistically and clinically significantly higher than time zero. This is more consistent with vasogenic edema, where you have free flow of fluid in the extracellular tissues. So now how do we correlate that with children? So this, by the way, I'm just going to take it back again. This slide is replicated in this little, that's the slide down here. Remember, rats that are control, time 0 DKA, 6 hours after fluid and insulin. Now these are children. This is a study that Nicole and I did. This was the scariest study I've ever done in my life. You take kids sick with DKA, they've been resuscitated, and then you take them down to the MR scanner for an hour. No pharmacological sedation. You just say, Johnny, hold still. And they're sick with DKA, and it's at 3 a.m. It was no fun. But this is what we found. So this is the imaging that correlates to this time, because this is at about 6 hours in. We've resuscitated them when we started insulin drips. So it's the equivalent of this time in the rats, that third purple column. And what we see is high ADCs. Again, this is ADC on the y-axis. This is high ADCs. And then this is their imaging after they fully recovered from DKA. They normalize their ADC. Again, consistent with at time 6, when we typically see serious decompensation, high ADC, consistent with fluid in the extracellular space. So the kind of summaries from those experiments were that ADC values are low in untreated DKA, suggesting cell swelling. ADC values are elevated during treatment with fluid and insulin, suggesting vasogenic edema. And these patterns of change in ADC are very similar to ischemia and reperfusion injury. And the high ADC values that we see during DKA treatment are not consistent with what we were taught about the fluid shift. So again, just another piece of evidence along the way. So a randomized clinical trial was really needed to be done. And why had it not been done? This is remember what Elliot Crane had said 20 years earlier. First of all, it's difficult to organize a big randomized trial in DKA to answer these questions. At the time, there was a lack of expertise in emergency medicine research, but that's been growing over time. And we didn't have the infrastructure to do it, like PCARN, to do the trial. But the last one, and I will tell you, was fear. So when we did this trial, which I'll talk about in a second, in PCARN at the time had 18 sites. Or actually at the time it was like 22 sites. So we proposed this randomized trial, a fast fluid versus slow fluid. This is Nicole and I proposed this. And it's not that they were extreme, but and we got like 4 takers. Even in PCARN, the research network, 4 sites was not going to be enough. So we had to bring them a little bit closer together, make people a little bit more comfortable. Then we got like 8 sites, still not enough. So then we had to bring it a little bit closer. We got 13 sites and we went with it. But still 5 sites did not want to participate because of the 1980s studies that 4 liters per meter squared per day. And everyone will say, well, I haven't seen a case of cerebral O in 20 years because we manage it this way. Well, you know what? They've seen 3 of them over there and 2 of them over there, and they're managing it the same way you are. It's an uncommon event. So you cannot count on your own experience. You need to use the pooled experience. So we did this trial that was published in the New England Journal. Ironically, this is about 20 years after that first New England paper. And I'll tell you, I'll cut to the chase. It found the same thing. Now, I purposely posted the accompanying editorial. My hero, Mark Sperling, who wrote a nice editorial about the study. But this is how the study was done. It was called the fluid study in DKA. And it was a prospective multi-center study in PCARN. 2x2 factorial design means that we were studying 2 things. We were studying both the rate of IV fluid, but also after the initial bolus, normal saline versus half normal saline. We did not, unfortunately, have a plasma light or lactated ringer's arm because that was, we started this a decade ago. 13 sites, about 1,400 episodes, standard definition of DKA, and we excluded children who had underlying neurological conditions that clouded the picture of their neurological status, and if they had already received too much fluid, because like you, we get a lot of referrals in. So patients that have gotten too much fluid, they couldn't be randomized. And this is how the arms look. So the yellow are the fast arms, and I'll explain that in a second. The blue are the slow arms. And A1, everyone got their bolus with normal saline, but afterwards, the rehydration, half of the fast ones were half normal saline and half normal saline, same for the slow ones. So factorial design. So the assumed fluid deficit, so to justify the amount of fluid that we're using, because, and now we have subsequent studies on this as well, but we assume in the fast arm that they're 10% dehydrated, and in the slow arm, we assume they're 5% dehydrated. The standard bolus we use in the fast arm, 20 cc per kilo bolus of normal saline, in the slow arm, 10 cc per kilo bolus of normal saline. And then the deficit replacement in the fast arm, we replaced half the deficit over 12 hours and half over the next 24 hours. And the truth is that most kids by 12 hours, they're rehydrated. So it's really giving the full rehydration in about 12 hours in the fast arm. And in the slow arm, it was rehydration was evenly over 48 hours. So just to give you an example, for the typical 20 kilogram 5-year-old child, the difference in the fast arm versus the slow arm in the first 12 hours would be about 1,700 cc's of fluid versus about 900 cc's of fluid for the first 12 hours. And our outcome measures were first a decline in the GCS score to below 14 that was persistent. They had to have it and then reassessed and remain low. We also looked at clinically apparent cerebral edema. That is the big bad cerebral edema. Intubation, death, hypertonic saline, mannitol, etc. And then we brought all the children back 2 to 6 months later. Oh, I'm sorry, I'll talk about it in a second. The third thing that we measured in the hospital is a digit span recall test. And what this is, it's a very sensitive test. The part of the brain that is most susceptible to hyperperfusion, hypoxia, is the hippocampus. And that's associated with memory. And it's interesting, I spent a year in Nepal, as Loretta knows, during the middle of my residency. I took care of a lot of high altitude climbers. They can't remember anything because it hits the hippocampus, and that's your memory center. So we measured that during DKA, and the way you do it in children is it's a digit span recall test. We do it every 4 hours while they're awake, and you give them a list of sequential numbers read out aloud, and then they have to repeat them to you until they can no longer remember. And then you do it backwards as well, and that's sort of a very inexpensive and easy way to assess short-term memory. And then we brought everybody back 2 to 6 months later to look at long-term effects, knowing, however, that these children, a bunch of them had previous episodes of DKA and whatnot, so it's hard to know how much was due to this one episode. But we looked at memory, working memory, episodic memory, and IQ testing. So this is what we found. And first I'm going to show you the power of randomization, because when you have a big cohort, 1,400 kids, the arms look really similar, and it's really important. So first of all, the mean age you can see across all groups was about 11 years old. Half of them were boys, half were previously diagnosed, and you can see just identical throughout all groups because it's a big randomization cohort and things become equal. Years since onset for the children that had known diabetes was about 5 years. The vast majority presented with the GCS, a normal GCS, and you can see about 9% presented with GCS of 14 or lower. And this is important. Look at the, again, in the yellow, the glucose numbers, I mean, identical between arms, pH. So there were some sick kids. The average pH was 7.1617, which means a lot of them had 7.0 and others had 7.25. So they all looked good at baseline. So these are the most important slides coming up now about this study. So we looked at, remember, our primary outcome was drops in GCS that remain consistent. And in the fast arms here, about 3% had that event, and a little bit more than 3% in the slow arms. The p-value, not significant, but you're going to see in every statistic, the point estimate all points in the direction of favoring fast fluids, although, again, not statistically significant here. How about the big bad cerebral edema? Here we're talking about intubation, mannitol, death. 4 occurred in the fast arms, 8 in the slow arms. Again, p-value, not significant, but of course, the point estimate pointing in the direction favoring fast fluid. And then there was no difference in the type of rehydration fluid that was used. Now people ask, well, what about the sickest patients? So this is the slide of the sickest patients. So these are patients with the pH or the PCO2 in the lowest quartile, the highest glucose, the highest BUN, or the highest BUN and glucose. Again, the fast arms and the slow arms. And here you're starting to see those same differences, but now the p-values are starting to approach significance. Again, favoring fast fluid. Again, although we weren't trying to prove that fast is better than slow, we were just trying to prove that fluid is not causing cerebral edema. But having said that, all the point estimates point in the direction of fast fluid being better for these children. And then the working memory, this is the forward digit span, and don't worry about the numbers, but the point is that even for the memory, not significant, but really close, favoring the fast fluid during DKA. And then finally, when we brought people back, I'll summarize the slide by saying there was no difference in the groups at 2 to 6 months out, because that's a very complicated time, because you have to adjust for all sorts of events that have been happening in these kids' lives, but no difference at 3 months. So the implications of that study was that rapid infusion of IV fluids is not associated with cerebral injury. You want to avoid underhydration of children with DKA. Acute kidney injury and other complications related to volume depletion exists. So you want to treat hypoperfusion with fluid boluses. And basically, the treatment fluid in DKA is you take a reasonable balanced approach to rehydration, just like any other acidotic dehydrated child. That is the answer to that question. Okay, let's quickly move on to the last few. They're shorter, but I want to get through all this. What about, so we busted the myth for number 3. This is the next question. Monitoring serum sodium levels important to ensure that sodium is rising. So I mentioned that in our retrospective study from 2001, we, as well as Harris, have found that the failure of sodium to rise during DKA treatment was associated with cerebral edema, and I document that. We have to remember, though, that these studies were done retrospectively, only identified when children were getting intubated well into their course. So up until this time, many protocols had recommended monitoring of serum sodium. But now I want to point out what an article we published in Pediatrics last year of serum sodium in the DKA trial. And I'll walk you through this. These are looking at children in the first 4 hours of therapy, the first 8 hours, and the first 12 hours. This is the serum sodium being stable or increasing, and this column is sodium decreasing. And these are different categories of children. So in the first 4 hours for children who had a low GCS score, a basically equal number of children had increasing sodium versus decreasing sodium. For those with the big bad cerebral edema, again, there's not that many of them, but identical between the groups. That is, equal number had increasing versus decreasing. And the same thing for 8-hour outcomes and 12-hour outcomes. Basically, no difference between the children doing poorly and doing fine in terms of were the sodium trend increasing or decreasing. And this is, the statistics are complicated, but I'll say this is a slide looking at 4-hour time intervals now. Hours 0 to 4, 4 to 8, 8 to 12. This is normal, this is for children with normal GCS who have stable or increasing sodium. And those are for children with declining in GCS who have stable and increasing sodium, and normal GCS patients. And on the left are the actual numbers that we observed. And on the right is using, a multinomial, a very sophisticated statistical technique, assuming that there's no correlation between sodium and cerebral injury. What would you expect the number of children to have these things? And you can see the left column and the right columns are identical. This slide shows that what you would expect to see if there was no association between sodium and cerebral injury is what we actually saw. Another piece of evidence to support that sodium is not important. So why were these prospective and retrospective results different? Well, first of all, as I was mentioning, patients in retrospective studies, typically, first of all, they didn't have frequent monitoring of their mental status. So if you had monitored them from the start, they already had decreasing mental status, but they were documented with their cerebral injury only at the point of intubation or hypertonic saline, etc. They had more severe CI and worse outcomes. Sodium levels were only measured at the time that they're having their bad injury. So our hypothesis and those of others is that when you see that failure of serum sodium, those who are children with bad injury, they have a brain event. It's like SIADH, or in this case, cerebral salt wasting, likely explaining it because kids with, early events and whatnot, you don't see it. You only see it until you see it when the brain event is bad and is sort of irreversible. Okay, almost to the last bullet, urine and creatinine are often elevated in DKA. It's due to decreased kidney perfusion. This is what we would have learned and has been resolved with fluid replacement. But we have actually studied, Hirsch et al. This was a fellow in Ottawa. She was studying DKA and renal injury, and they got us thinking about this. They thought, oh, God, we should look at it in our cohort. And we found that 43% of our patients with DKA have acute kidney injury. About 40% of those, it's grade 2 or 3 severe kidney injury, although none of them required renal replacement therapy. The other thing that we found is that somewhere between 20 and 40% of the patients in our study have pyuria, sterile pyuria. They don't have UTIs, suggesting that there's some potential inflammation going on in the kidney. And the other important point is that you can see the third bullet. Not only do we have these findings, but the children with AKI, they had lower IQs at follow-up, lower memory scores, suggesting that there is sort of like a MODS, a multi-organ dysfunction syndrome happening, because we're clearly seeing events in the kidney, we're seeing them in the brain, and it looks like they're both related to inflammation. And then this is a study that we just recently published. I find it fascinating because the question is, so these DKA events, do they portend or increase your likelihood of having chronic renal disease as an adult? That's a major problem. So this is a study that we did. It was just us at Davis and CHOP. We took more than 2,000 kids and we followed them, in this database from 2006 on, and we looked at whether they had one episode or more of DKA. We limited to those with one episode, and we adjusted for everything else: hemoglobin A1C, socioeconomic status, other things that would potentially be associated. And what you're seeing in the survival curve is that on the y-axis here is the proportion with microalbuminuria. That is the earliest sign of chronic renal disease. And again, this is adjusted for all those factors. And you can see this is the time to having microalbuminuria. If you had no AKI during DKA, then the curve is here. If you have AKI during DKA, the time to developing microalbuminuria is significantly shorter, suggesting that there may play a role in chronic renal disease. Really important because, of course, chronic renal disease in adulthood is a major issue. And then the final thing I wanted to mention is the myth, actually, that most children with DKA recover with no long-term consequences. So we know that the big bad cerebral edema that we were talking about with intubation, et cetera, that happens in about 0.5% of DKA episodes, 1 in 200. But that just represents the tip of the iceberg, because what we have found, and Elliot Crane, the person at Stanford I mentioned to you, was the earliest investigator that found this, is that subclinical cerebral edema is very common in kids that look neurologically normal to you. He had done studies of imaging of kids with DKA who looked fine and saw a lot of cerebral edema. So we decided to study this again with MR imaging, Nicole and I, and this was just at UC Davis. Here is MR imaging. This is the lateral ventricle size on the y-axis, and on the x-axis is during DKA treatment and after recovery. And again, if the lateral ventricle is smaller, it's being compressed with edema. And we see that it happens frequently during DKA, and then it goes away after recovery. But the question is, is it associated with any cognitive or neurological decline? And in fact, what we found is that about half of the 41 children who had ventricular narrowing during DKA I'm sorry, so half of the children, I'm looking at my GCS. So just give me a second here. So half the children with ventricular narrowing had abnormal mental status as assessed by drops in GCS versus only 20% of those that did not have that ventricular narrowing. And this is something that you wouldn't pick up clinically. These were just subtle findings that you have to investigate prospectively, either with memory score testing or very careful GCS testing. Again, suggesting that subclinical cerebral edema is actually not subclinical, it's subtle clinical finding, but it doesn't result in hypertonic saline, intubation, etc. So cerebral edema is not only common in children with DKA, but also is evident with some subtle neurological injury. And this is the final study that I'm going to show from our big PEAK-RUN study. So this was looking at children, a neurocognitive study run by our PhD neurocognitive expert. And this is looking at our children at 2 to 6 months after their DKA event, and looking at what were the risk factors for having, these are abnormalities in neurocognitive testing. There's a color task, the IQ score, and the digit span recall done 6 months afterwards. And the important finding here is that your DKA status, which is you had no DKA, mild DKA, or severe DKA, that was an important factor at 6 months out, looking at IQ and other factors regarding neurocognitive status. And importantly, here you see it's no DKA versus mild versus moderate. The color task gets worse with more severe DKA. The IQ, this is a significant changes, 105 to 100, and the digit span recall test. So these are subtle but important factors that we're seeing after one DKA episode, after adjusting for all these other factors, and particularly important in a disease like diabetes, where you need all your neurons to be firing to manage your disease for your lifetime. So what causes cerebral injuries? Are my last couple of slides, and we'll be done. What causes cerebral injury in DKA? The older theories about excessive fluid, we know they have proven to be incorrect. So what looks to be the pathophysiology after 20 years of rat studies and human studies, probably a combination of hypoperfusion and neuroinflammation. And in fact, many investigators, including ourselves, have identified elevation of a lot of inflammatory factors during DKA. Aroscaro, a PCM, a physician who fortunately died a couple of years ago, one of our close collaborators, showed an elevation of matrix metalloproteinases. These are things that you see post-stroke with inflammation. So there's all these markers of inflammation in the setting of DKA. And this is the most interesting slide that I have. So this is the hippocampus of juvenile rats, okay? This is juvenile rat hippocampus control, normal juvenile rats. This is a juvenile rat with hyperglycemia, but without DKA. This is a juvenile rat with untreated DKA. This is DKA at 4 hours after therapy, 24 hours of therapy, and after 72 hours. And what you're looking at here, the green is the neuronal layer, and the red are the glial cells, the scaffolding, the infrastructure that helps support the neurons. And what you're seeing is over time, the glial cells, they're getting very inflamed. They're not inflamed in control animals or hyperglycemia a little bit, untreated DKA, but look at 4 hours after treatment, they are super inflamed. And not only that, they're breaking up the neuronal layer. They're having an impact in the neurons as well. So if we put this all together and kind of create our construct of what's causing cerebral injury in DKA, we have the child who's acidotic, hypocapnic, has cerebral vasoconstriction, they're dehydrated, hyperglycemia leads to decreased cerebral blood flow, and ketosis. They have hypoperfusion and cellular edema. And in the setting of this tremendous inflammation, you then have to rehydrate them, and they have a rehydration injury. So now finally, going back to those 6 points, the resolution now in 1 month away, February of 2023, DKA is a complication not only of type 1, but also of type 2. DKA is treated with insulin and IV fluids. That remains true. DKA should be treated with IV fluid resuscitation, similar to any other child with any other condition who's similarly dehydrated. Cerebral injury and edema is likely caused by abnormalities in brain perfusion, along with neuroinflammation. Acute kidney injury occurs commonly in DKA, leading to elevated BUN and creatinine levels, but it's also associated with subtle impacts in the brain, suggesting a multi-organ inflammation. And there are long-term consequences of DKA after recovery, including increased risk of diabetic kidney disease and subtle decline in neurocognition. And with that, this is a picture from the movie Red, and you notice Dexcom, glucose monitor. It was great. They just threw it in there, just normalizing the care of diabetes. Sorry that was long, but we have a few minutes open for questions, and thanks so much.